and the committee for the vascular art. Now I only speak for a very important subject that we all facing the cases of venous thromboembolism. The venous thromboembolism is a significant cause of morbidity and mortality that affect approximately one per 1,000 of population, with annual estimate of 600,000 cases of clinically significant pulmonary embolism and about 200,000 deaths in the States. For most situations, VTE is effectively managed with anticoagulation, which is associated with decrease in the recurrence of pulmonary embolism and lower mortality and the acceptable low risk of bleeding complication. But unfortunately, some patients, there is anticoagulation inefficiency or contraindication or resulting in complication requiring it to be discontinued. In this situation, vena cava interruption with filter is advised or recommended. The filter design consideration, the functional goal of the filter is to prevent pulmonary embolism by trapping venous thromboemboli in the vena cava, not to prevent or treat the venous clot. The filter should have a self-centering mechanism with secure fixation to the vena cava wall to prevent migration, and the optimal filter should be highly visible in imaging with ease to percutaneous delivery through a low profile system and simple release mechanism and repositioning, and also for retrievable should be safe and possible. This is the filter design. We have two types of the filter: conical filter design like umbrella, and the double basket design fusiform that have higher capacity to capture small emboli but may be associated with higher vena cava occlusion. The vena cava filter category, we have four categories of vena cava filter: permanent filter, and has design characteristic that maximize secure fixation. Temporary filter is attached to a wire or catheter. Optional or retrievable filter has a feature of removal capability with device-specific time interval. It is an retrievable one. And the convertible filter can be altered structurally after implantation to non-filtration state with removal of the filtration portion through a separate percutaneous procedure. This is the type of retrievable filter. The recovery filter from BART, the tulip filter from Koch, and the Celeste filter from Koch also, Optase filter from Quartz, and option filter from Medical Essence, and Equiblaze filter from BART. So there is many types or many shapes of the filters to guard against the propagation of the thrombus to the pulmonary arteries. This is a Venetech convertible vena cava filter and should only be performed using ambulance goes neck, snare, angioplasty balloon may be used to assist its completely opening, considering the fixation of the leg of the filter. Very important is the IVC size. The size of the IVC is 28 to 31 millimeter, most filter work. But the larger size of IVC, like 32 to 40, the only option is to use the bird's nest filter of the Koch. So it is very important to measure the size of the IVC before inserting the filter. The evidence-based indication of the filter: documented VTE with contraindication to anticoagulation, documented VTE with complication of anticoagulation, recurrent pulmonary embolism despite therapeutic anticoagulation, documented VTE with inability to achieve therapeutic anticoagulation. And the relative relative indication of the filter: poor compliance of the anticoagulation, free-floating ileocaval thromba, renal cell carcinoma, venous thrombolysis or thrombectomy, documented VTE. Documented VTE with high risk of anticoagulation complication, recurrent pulmonary embolism complicated by pulmonary hypertension, documented VTE with cancer patient or pregnant patient with pregnancy, prophylaxis of high-risk surgical patient, prophylaxis of high-risk trauma patient, prophylaxis of high-risk medical ill patient. This is the prophylaxis filter for high-risk patient in the ICU and in trauma patient. The contraindication, there is the chronically occluded vena cava. It is for sure it is contraindication to use a filter because of the obstruction of the vena cava, presence of anomalies of the vena cava, inability to access the vena cava, or vena cava compression, or there is no location in the vena cava available for the placement of the filter. The complication of the filter, it is very important to measure the cost effectiveness of use of the filter or not use of the filter. There is some complication like pulmonary embolism in about 2 to 5% of patients. It may be fatal in 0.7. This linked to filter insertion, it is very low, 0.12. Venous exercise thrombosis, filter migration, vena cava penetration, vena cava obstruction, venous insufficiency, filter fracture, or guide wire entrapment. There is so many complications of the filter, so we must stick to the guidelines when indicated to insert the filter. This is a coronal image or CT sonography showing the hypotense non-enhancing thrombus in the filter after insertion. And also the inferior vena cava filter migrated to the apex of the left lung, as we show here. It is one of the complications of the insertion of the vena cava filter. And also this migration, we can looping the filter to retrieve the filter, and this is after retrieval of the filter in the left one. Permanent versus optional filter. Although the potential for significant adverse outcome with permanent filter is low, there are long-term complications that could be avoided by retrievable filters. In patients with proven venous thromboembolism, anticoagulation should be resumed as soon as possible when the risk of bleeding is diminished. Potential retrieval at extended periods is possible for all filters, can be more problematic with a higher failure rate. So when we retrieve the filter after insertion in about 1 month, the successful rate is about 99%. And after 3 months, it's 94%. And after that, after 1 year, it may reach to 37%. So when we need to retrieve the filter, we must retrieve it as early as possible when it is not no indication for the filter. Retrieval fault should be considered in the following clinical scenarios. Indication for permanent filter are not present. The risk of clinical significant pulmonary embolism is acceptably low. Return to high risk for venous thrombosis is not anticipated, and the life expectancy is long for the patient. When the filter can be retrieved, when there is a defined retrieval endpoint determined by when anticoagulation can be restarted safely and or when pulmonary embolism risk has diminished. So we can retrieve the filter in this situation. The placement of the IVC filter, we must know the anatomy of the IVC. We usually placing the IVC filter below the renal veins between the lower part of the lumbar vertebrae 2 and upper part of the lumbar 3, as we show here. This is the different anatomy, and this is the site of the filter. We recommend to place the IVC filter through the renal veins between the lower part of the L2 and our part of the L3. This is the anatomic, very important anatomic variation of the IVC. This is the normal IVC, and this is the duplicated IVC, and this is the duplicated IVC right more than the left, and this is left-sided IVC, and this is pre-aortic IVC, retro-aortic IVC, circum-aortic IVC, and the accessory left renal veins. This is very important to know the anomalies, and so we must do venography before we insert our filter to put in the right position. For duplicated vena cava anomalies, placement of the filter in each vena cava or in the suprarenal vena cava after the left renal vein crosses over is required. Technical consideration, venography is very important in imaging guidance technique for placement of the IVC filter. Placement of the filter of the infrarenal IVC has been the standard position with appropriate IVC diameter, straight alignment to avoid renal vein thrombosis, and flow dynamic consideration. Bedside placement of the IVC filter, sometimes the patient in the ICU and its movement is dangerous for the patient, so we can insert the filter using the duplex ultrasound when we see the tip of the filter and the guidance by duplex ultrasound. Venography guided filter placement, it is a standard approach of the most IVC filters. This is a non-selective venography depending on the level of the bones. And this
Could I please ask you to go to the conclusion, because we're running out of time.
So I jump to the conclusion of my talk. There is a filter retrieval, and it is a method of retrieval of the filter through the femoral or jugular axis. And these are types of the filter what we can retrieve. So the guidelines for the using of the filter, the ECVS recommendation is for patients with proximal DVT who have contraindication to anticoagulation during the initial or principal treatment phase, temporary inferior vena cava filter insertion is recommended. This class A, level C. Are for patients who are anticoagulated for deep vein thrombosis, the routine use of IVC filter is not recommended. This is the recommendation for using of IVC filter. And thank you very much for your attention.